So, as Paul said, I'm the chair of Tech Quality, which, as Alison's indicated at the beginning of the day, has the only externally validated quality service framework for tech services in the UK. And there are currently 160 organisations who have got the QSF award. There are 20 in progress from 2021 who've applied, and we are dealing with 16 new applications. So my question to you is, given that this is a way of verifying the quality and safety and effectiveness of your services, if you aren't one of those nearly 200, could I urge you to consider it? And if you want to talk to me about it during the conference, I'd be delighted to talk about it. But the point I wanted to make about this is that there are a number of things that I think it gives you. First of all, it ensures that people who buy the tech services and those who rely on it can have confidence in it, which is pretty significant. So if we think about Pam this morning in the video, she talked about confidence. I think she said something like, the people are keeping an eye out for me. They therefore they know if anything's going on, and I feel safe because I don't feel on my own. And if you like, that principle of confidence applies to the whole of the quality assurance process. Secondly, I think it can help an organisation steer its future approaches and strategy. And since we're talking about things like embedding personalised care, how do you do that in reality? And who can help you do that? Because it's easily said, isn't it? But it's much more difficult to put into place. And thirdly, it can help people to understand how to navigate the challenges, be it things like, well, we've just been through the COVID pandemic and we're not out of it yet, but helping to navigate those sorts of things, or analog to digital. So it helps to build resilience and sustainability. And I think the other thing that it can do at a time when this can never be more important is to encourage and support the workforce with safe and effective approaches. And clearly, right across the social care and health sector, we have a job of work to do to enable people to use evolving technology as part of the wraparound care, as part of the personalised approach, in a way that they can have confidence in. And finally, one of the things that the team have done is when they've aggregated up some of the issues that have arisen from audits, they've come back and said we need to pay attention to things like prevention and things such as falls prevention, because those are some of the things that have actually come up in the range of audits. And so within TSA and Tech Quality, we've set up special interest groups in order to address that we feed them back into the sector. So there's if you like, a virtuous circle. I then want to quickly move on in the last bit of mine to set the scene around the Personalisation Agenda and delve a little bit more briefly into the provisions in the white paper from England. But it's true to say, as we heard this morning, that there is a remarkable similarity between the strategies in England, Scotland, Wales, and indeed Northern Ireland. So this is by way of an example. And what I was struck by when I read the English white paper was the I statements, which I think are always good for grounding us in what our job as people who are leaders and passionately wanting to deliver the best social care services with people that we can. So in the white paper it says one of the things that people should be able to say is, I can live in my own home with the necessary adaptations, technology and personal support as designed by me to enable me to be as independent as possible. And if we're thinking about what personalisation means, I think that's a pretty good definition. So I commend it to you. And for how we're going to deliver this, and we're not quite sure yet, because there's still work taking place in government about how to spend the pots of money that Michelle Dyson referred to this morning, or indeed the points that Caroline Lamb made about Scotland. So it's continuous work in progress. But what government are saying is they want to work with a range of people to ensure that people can adapt their homes and access practical tools and technology in order to live independently and well in their own homes. And I have to say that I have been in social care for many decades, and I haven't seen a statement and commitment quite like that. So I think there is an opportunity for us to seize here. And the TSA ADAS paper, which I know Stephen's going to refer to in a bit, so I'm hoping I'm not stealing his thunder, really did, I think, give some substance to what that might look like. And it said in 4 planks, technology-enabled services need to be proactive and co-produced with people, with their families and carers. So how do we do that? How do we build that in structurally around our individual services as well as with the individual? Because it needs to operate at all different levels. Digital infrastructure skills and approaches must improve so individuals and the care workforce can maximise digital opportunities. So what that says to me is that we've got 2 clauses there. First of all, the infrastructure, which is changing all the time, and how do we move from analogue to digital safely, or indeed integrate the best of all of that so that people can have their Internet of Things that help sustain the independence that people hold so dear. And people must have choice and control of the health and social care data and enable access by the right people at the right time. And I've certainly had some interesting conversations, even in the last few hours, with some of you about the way in which data from technology-enabled care is informing the health and social care system about risks, and so that the whole system can work together to support that, provide that person-centred coordinated care. And the final point is more collaboration is needed in care and support across all sectors, so that the policies are joined up and contribute to the wider well-being of people, their families and carers. So it's a complicated world, isn't it? And there are several hundred tech providers in this country. There's 152 local authorities. There's 18,000 providers of social care working in 39,000 settings. It could not be more complicated if you want to move things at scale. But it will take each and every one of us to think about how can I contribute to this mission? Because the need is not going to go away, so there's room for everybody. We don't need to compete, except when we're in a procurement process. We can afford to work together to get this right. So it seems to me that what we're aiming for is something that is personalised, effective, of sufficient quality, and financially sustainable. And I want to finish with some advice that I gave to a ADAS TSA seminar in London, which some people decided to write down. And I want to throw it open to you for your thought and consideration. How can we all, that's you and TSA and tech and the sector overall, best position ourselves to take advantage of the opportunities that these approaches provide? And in that I've got in mind that as part of the health and social care integration, integrated care partnerships will have a responsibility for delivering strategies for health and care. Wouldn't it be great if every single one of them had some substance around technology-enabled care as part of its brief? Do you and do we have the mechanisms in place that will enable us to do this? So that's for you as organisations, but it is for us collectively. And going back to those strategies, what strategies do need to be in place, and what are the resources that are required in order to do it? So I'm engaging that, although we're not having a conversation, as a conversation for you to think about, and for us all to think about how we can make progress on embedding personal care. Thank you very much.
David. Thank you very much indeed, David. And do take those talking points as the basis for conversation this evening. And David, I'm sure, will be very pleased if you all line up and come and have a chat with him during the course of the build-up to the gala dinner. So now we're going to move on to our next speaker, and that is Stephen Chandler. He's the Chief Executive of Oxfordshire County Council, and also, I think, the Director of Adult Social Services at Oxfordshire County Council, and is also this year the President of the Association of Directors of Social Services. So he's got a few things on at the moment. And I just wanted to say thank you to Stephen and to the Association of Directors of Social Services, with whom we have built and developed, I think, an ever-deepening collaboration over the last few years, which I think has culminated most recently with the Commission that I think Stephen is going to touch upon in his remarks. Over to you, Stephen.
Thank you, Paul, and good afternoon, everyone. So let me just begin with saying thank you. That's a thank you to you for everything you've done, not just in the last 2 years when we've had COVID, but before that, but also especially through COVID. It's only been through your contribution, your organisation's contributions, that we've been able to really ensure that our most vulnerable were able to be kept as safe as possible, to remain as independent as possible, and to live the lives that they wanted during the pandemic. So thank you for that. So I just wanted to start with that. So despite Paul's reference to the number of responsibilities I have in my work life, I'm also here like a number of you. I'm a son, I'm a father, I'm a husband, I'm a brother. And it is those attributes, as much as my professional attributes, that I feel help me and place me well for this conversation. Because I don't know about you, but as all of those, I want to remain independent. I want my mum to remain independent as she enters her 80s, but I also want her to be safe. I want myself to be as independent as possible for as long as possible. I surprisingly don't look forward to the day when I might have to knock on my local authority door and say, can you help me? Not because I don't think my local authority won't do a good job, but rather I don't really want to be dependent on others. Though, as I've previously said on a few occasions, each and every one of us is just one life-changing event away from needing that care and support that often starts within local authorities but could equally be within the NHS. So for me, as an individual, for me as a family member, never mind for me as a professional, remaining independent through whatever means, and of course technology helps us so much in doing so. So for me it's an absolute privilege to come along today and to speak to you. So is this a personal view or not? Well, as you can see, ADAS members really see the value in technology through digital. We see the value in it through the work that it helps us do in, as I've just said, keeping people independent and well for as long as possible. We see it in helping us manage that ever-increasing demand for support that we see out there, not just COVID and pandemic related, but by virtue of us living longer, fantastic, but nevertheless brings with it an increase in demand. So technology helps us as directors and as leaders to manage that demand in a way that ensures people have maximum amount of choice and control. It also helps us manage our resources as carefully as possible, because you won't find a local government employee, whether it's a director or a chief executive or whatever, saying we've got too much money. Clearly, we're working in very difficult financial circumstances. But also, it is important, and you as an audience will probably tell me this even stronger than I can articulate, it is important that we invest in technology as we move forward, to ensure that we're remaining current, that we're enabling all of the myriad of choice out there to work effectively together, and for us not to remain stable, because if any part of our lives has changed phenomenally, it's the impact of technology, whether that be digital or physical kit in its own right. So, as you might imagine, we've not been resting on our laurels, and as both Paul and David said, we've been working really, really closely with the TSA through the Commission, and as you can see, drew some really helpful conclusions there as to the value of technology and the impact that technology can have on people's lives, on managing scarce resources, on working closer and closer together, whether that's with the NHS, who's often cited as our primary partner, but also with police, with fire, with other members of the public sector family. We can't emphasize enough the power that technology gives people in remaining independent. But of course, we have to overcome the confidence, the assurance, the availability, etc. But think back in your own lives. I remember I was a joint commissioner in Worcestershire in 2004, so very nearly 20 years ago. And I worked across health and social care. And I started with 2 laptops, one connected to the NHS sector and one to the local government. By the end of my time there, which was relatively short in the scheme of things, I had 1 laptop that was able to access both systems. And there was an increasing use of information in that sense to manage the role I was in. Now, that was nearly 20 years ago. I was in a conversation recently in Oxfordshire where people were saying, well, I'm not sure we can share that data. Why not? Well, information governance rules might not be there. Well, what did the pandemic teach us? What the pandemic taught us was where there is a will, there is a way. Where there are rules, they can be used to our advantage, but also they can hinder us. So for us, it's really, really important that we come at this, not just with the resources, but with the right outlook and mindset. So I've just got one more slide, which I'd like to just spend a few minutes focusing on, which is, it draws upon the recommendations of the Commission, but it also, as you'll see, has an overlay of my personal and professional experiences. So, leadership. So where does leadership start and where does it end? Well, for me, leadership starts everywhere. I've worked with some fantastic leaders during my career. They won't necessarily have all seen themselves as leaders, and in fact, they won't have had leader or indeed manager in their job title. I remember working with an occupational therapy assistant who told me that the process we had for faxing referrals for equipment changes was unhelpful, unnecessary, and didn't result in that. And I said to her, what do we need to do? She said, well, you need to stop asking the question because I found a way around the system. So she taught me, again, coming back, where there was a will, there was a way. Equally so, the challenge of COVID showed us that when we all focused on a critical emergency, we could still remain legal, yet deliver far better outcomes in comparison to what was possible before. Better outcomes in timely decision-making, safe decision-making, quick and appropriate person-centered decision-making. So what I would say to you, whatever your role, step into that leadership space. Step forward, be a little bit like my 8-year-old and say, why? 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 When somebody says to you, oh, no, we haven't got an information sharing protocol, so we can't do that. Why? Why haven't we got an information sharing protocol? Oh, well, we can't do that because that piece of technology is not on our framework. Why? 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 Keep going. Keep that constant challenge to ensure that the art of the possible that we see up and down this country being delivered to individuals, to groups, becomes the norm. But of course, it's not just about getting to that point. It's about staying at that point. And as you'll know, in the world of technology, constant evolution is the norm. I've mentioned briefly, as I've spoken around, the importance that technology can play as we deliver personalised care. I haven't really mentioned enough probably in relation to integration, but of course, when you find yourself in touch with either health or social care, you don't really want the nightmare of having to tell your story once, never mind twice, never mind 3 or 4 times. And certainly if you've become unwell, you really want that information to be there immediately. I wasn't feeling very well last week. I rang my GP and the first thing I said to them when I got through was, you'll see from my records that up until now I've been a very healthy individual. And they said, well, we haven't got your record up. I said, well, pull my record up. Interesting, slight aside, when I told my wife this, anybody want to shout out what they thought her comment was? Her comment was quite simply, what's the password to the password generator? Because she was worried that the technology would end up crashing if I wasn't there to keep it going. However, let's finish though on a serious note. We have a real opportunity through the use of technology to deliver much better outcomes to the people that we are currently supporting and to us as we are likely in a lot of cases to need support in the future. So it is beholden upon us. It's our responsibility to ensure that that opportunity is not missed, that we bravely go forward, challenging the status quo, leading an emerging system and support that each of us can be proud to be not only part of as professionals, but to be proud to receive should we need that support. So I'm going to finish where I started, which is just by saying a really big thank you to everything you've done to help us get to this point. A thank you for what you're doing today, but most importantly, a thank you for what you're going to do as we take this agenda forward. Thank you.
Thank you very much indeed, Stephen, and the power of why, and using that challenge, really, really important, I think, message amongst a great presentation. So we're now going to move on to a panel, and I'm going to invite up our panel of 4 who are going to walk over and take the seats. So I'm going to invite Kath Evans, who's the Deputy Director of Urgent Community Response from NHS England and NHS Improvement, to join us, and Caroline Williams, who's the Associate Director of Integrated Care, and Breed O'Brien, who's the Director of Innovation and Digital Health in National Digital Care Models, and Hugh Thomas, who's the Director of Finance at Hywel Dda University Hospital. I hope I got that nearly right. I'll be told later. Now you'll notice there's only 4 chairs. They've obviously decided, no, there's 5 chairs. I've not noticed there's a right number of chairs. Even better, someone put a chair in when I wasn't looking. Right, so we're going to come into another Q&A session, but before we do that, I'm just going to ask a sort of question of each of the panelists just to sort of get the ball rolling. Again, the app is available for people who want to type their questions. Please do, and I'll be looking at that as we go along. And please, it'd be lovely to have any questions from the floor as well. And there'll be people roving around with the microphones. They have paddles, and they'll indicate that. So I'm going to start with Kath and just ask you a question. Tell me a bit about your role and the Urgent Community Response Service.
Yeah, hello everybody. I'm Kath Evans and I work in NHS England and Improvement, and my role is to help roll out the national 2-hour urgent community response in England. This is a new standard, the first ever standard in the community health services history to have a waiting time standard. So the 2-hour urgent community response is a community response, as it says on the title, for people in a crisis and should receive a response within 2 hours. That care is provided by a multidisciplinary team, usually nurses, therapists and social care workers, and will deal with anything from somebody who's experienced a fall that needs a multidisciplinary team response or have become delirious, they might have a urinary tract infection. And the real main reason for that service is to prevent an avoidable admission, because up till now people haven't had a consistent choice across the country. If they need additional care in a crisis that needs some kind of intervention, and it's been quite ad hoc. So by the end of this month, in a few days' time, we will have coverage 8 till 8, 7 days a week, all across England. And I've been working with my colleagues here on such a programme.
Great. Thank you very much, Kath. So I'm now going to come to Caroline. And if you, Caroline, could tell us what your role is and what you do in Warrington.
Of course, I'm Caroline. I'm the Associate Director of Integrated Care in Warrington, which is one of the 9 places in the Cheshire and Merseyside integrated care system. Locally, I have the privilege of working across health and social care by way of our local council and our acute trust, heading up a portfolio of services that are designed not only to support people in their recovery and regaining independence after hospital, but more importantly to prevent people actually being admitted to hospital, and passionately believe in early intervention such that we can support people to live well and independently at home wherever possible. That brings me to some of the work that I've been doing alongside Kath and the national team in integrating services in the tech sector with the urgent crisis response service, such that we're able to provide people with a real alternative to finding themselves in hospital, which our esteemed colleagues, I think, earlier have shared with us, is pretty much where nobody wants to be unless it's absolutely necessary. And we know that our hospitals are busier than ever and also have a significant restoration and recovery programme ahead of them. So the important work that we're able to do in the community sector is now more critical than ever. And hence I'm delighted to be here to be able to take this opportunity as part of this panel, but also if you want to know more about the work that we're doing, there's a session in the innovation session later.
Great. Thank you very much. And moving along the panel to Breed O'Brien, can you introduce yourself and tell us a bit about the role that you play at NHS England Improvement?
Thank you. Good afternoon, everyone. I'm from the Digital Care Models team in the NHS England Transformation Directorate. And I've been leading a programme of work which is talking about supporting people at home through tech enablement. And it came about in COVID wave 1, actually, as a response to clinicians saying we've got too many patients to manage. Is there any tech that can help us? And our first virtual ward, tech enabled, was born. But it's gone from then to, I think last month we'd supported over 300,000 people at home. And when I say we, that's us at the centre, but most of the work is done by the local teams, both health and care, across England. And there's been 4 areas of focus. One, which is long-term condition management. So for anyone who's got a long-term condition, how can we enable them to self-care more? And for me, all of this work is not about, I think Paul said earlier, it's not about shiny new tech. It's people, process and technology. But more importantly, it's a culture change. This is about moving from what's been I'm a nurse by background, moving from what's been a predominant paternalistic model of care to one that's much more about partnerships. And that's a whole, partnerships has got a whole big piece to it, including trust. But the other 3 areas are supporting people with a serious mental illness to have their annual physical health check in a place at home or closer to home. The use of virtual wards and our work will no doubt, we collaborate on this, which is where people who would otherwise be in a hospital bed either avoid being admitted or leave hospital earlier. And I've spoken to some patients recently who've experienced this, and they talk about how safe they feel, because often, particularly with wearable tech, they're contacted by the health professional before they start to feel unwell. So that safety factor is huge. And then last but not least, we've done lots of work with the care home sector. And this for me has actually been one of the best learning experiences, because it is people, process and technology. And I know we've talked about shared records a lot today, and there is a need, interoperability, integration. There's lots of challenges. It's you know, we've got a road to travel. But particularly a conversation between a GP and a care home manager, and how their relationship has changed, the power base has changed. With technology, they're measuring vital signs. They've got a new score, which is a deterioration score. They have a different conversation with the GP, and the GP feels unable to make a different decision, which is often to keep that patient where they are, which is, you know, we all know if that is their home, and for 400,000 people, care home is a home, that's probably the right place for them. So yes, a really piece of work that spans all of what we're going to talk about, I'm sure.
Great, thank you very much. And then finally, Hugh, can you tell us a bit about your role and give us your perspective?
Great, thank you. Yes, so my name is Hugh Thomas. I'm Director of Finance for Hywel Dda University Health Board in West Wales, cover the 3 counties of West Wales. And we're an integrated health board across health, and work very closely with our 3 local authority partners. And as an integrated organisation, actually population health has been embedded into our thinking and the way in which we approach our challenges. And indeed, I probably, as a finance director, spend more of my time thinking about and working on ways of capturing and understanding outcomes for patients and people. They're only patients for part of their lives, than I do anything else. And there are some, you know, with every piece of work we do in understanding and capturing those outcomes, the consistent message always is that well-being, lifestyle, social interventions are what drive better health outcomes. And that's a pretty consistent measure regardless of the pathway that we look at. And of course, when we think about the value we're driving, then actually the value needs to be investment more in that preventative front-end opportunity, and that technology-enabled care is a fundamental part of that.
Great. Thank you very much indeed. So, looking at the list of questions, there are some coming in already, so I'm going to start going to the floor. But also, can we turn the lights up so I can actually see the audience? That will help us spot those that might want to ask questions. So there's a person with a panel over there and another person with a panel. So if you wave at them, hopefully they will then come to you. And I might call on Mark Jones, who has very kindly given us his name in the questions, as opposed to being anonymous, to start with his question, if I may. Are you here, Mark? I can hear a slight sort of voice very quietly up there. There we go. So we'll go to number 2, and then we'll come to number 1 in a moment.
With regards to the changes with the digital switchover, it's obviously going to, I think, cause some technical issues. Just wondering whether there's any support for housing associations with regards to funding of all the additional equipment that we're going to need to buy, and the subsequent changes to the equipment.
So I'm going to come to sort of look to the panel to see who might want to offer an answer on that. I think we heard this morning from Michelle Dyson that there are some things that are coming out from the Department of Health and Social Care, setting out how to go about preparing, and obviously the TSA, as long ago as I think 3 years ago, published our sort of, if you like, report setting out the challenges and the opportunities. But is anyone able to sort of maybe pick up on any of that around the digital switchover? Bree, do you want to come in?
It's not my area of expertise, but I know I've got 2 colleagues here today, both called Emma, so I'm very happy afterwards to connect with you, Mark, if that's useful. But yes, it's certainly part of the funding. But I think it's a bit like all of our work, and I think, again, it reiterates something that came up this morning. There is evidence. We need to build that evidence. We need to help build business cases, because this has to be a sustainable financial model. And I personally believe the evidence is there, but I'm an improvement person by background as well. It's evidence for improvement. So we just need to keep testing, iterating and building. But really happy to connect you with the Emmas. I can't see them in the audience, but afterwards.
Okay, so we'll try and make sure that happens. I'm going to hazard a guess. I think probably part of the answer will be that managing the changeover of equipment is something that will be expected to be part of an ordinary business cycle in terms of investment decisions. Now, obviously, where there's unexpected change, there's a legitimate challenge back to government about whether that change should require some additional funding. And I think there is a conversation to be had about how we make sure that we don't just change from an analog version to a digital carbon copy of the model. It's about how the model itself changes, which again is part of what TSA is very much up for. So there's a question here, and then I'll come back to the panel. Was there a question here? Yes, brilliant. Please fire away.
In addition to the priorities that you've identified, so preventing falls, preventing UTIs, what are the other sort of priority scenarios that you look into the digital technology to sort of help avoid admissions?
Okay, so I'm going to start with Bree, but maybe come to you as well, Hugh, and that, and others if they want to come in as well.
So across the country, lots of local systems are developing pathways that are pertinent to their local pressures, but there are two national areas of focus, and these were in the operating planning guidance for healthcare that came out on Christmas Eve. And they're around the frailty pathway, which of course we all know encompasses lots of other things. So there is a national pathway for frailty, and also building on the COVID experience and the acute respiratory illness pathway. So they're the two areas that as a minimum we expect all local systems to be looking to provide some tech-enabled virtual wards. But as I say, lots of local systems are also working on other areas, and we will take the learning from local systems, build on it, and make sure it's shared so that people aren't duplicating effort. But I don't know.
Yeah, I certainly endorse that from an adult perspective, and I'm sure there's many, many examples in children's services too, but certainly we know that our population is becoming increasingly frail, and our over 65 population spend a disproportionate amount of time in hospital, which only then further contributes to their frailty and poorer long-term outcomes for them. So I think we have a real key role connecting with tech services to actually identify people's needs and meet them in a much more proactive way than we're doing now.
And Hugh, did you want to add something?
Yeah, I guess clearly different policy context and different situation, but frailty is clearly an issue for all of us regardless of policy context, but that's dealing with an issue that is current and going to be with us for some time, and providing new models there is important. There's also an element for me about how do we become more proactive in the chronic condition management space. So for me that's really important, and we're looking at that in kind of areas like heart failure, COPD, and you know, that will help drive, I think, improvements further down the line, but it's more in that preventative space.
Great. Okay, I'm going to give notice to Daniel Casson. I'm going to come to you in a moment, so you might want to wave at one of the microphone owners to capture that. But before I do that, I'm going to come to Kath, if I may. I really just wanted, if you could say maybe a bit about, from your perspective, how we can get in tech services to get better outcomes for patients working with the NHS. How do we get this join up between the NHS and local government?
Paul. So I think one of the pieces of work we're working with, which is one of the reasons why we're here today, is we know a lot of patients, or we call them patients, you call them people, we're talking about the same people, that they use technology-enabled care services. But often if they've got a pendant alarm, they will press that pendant alarm, and that call may eventually be directed to the ambulance service. And we've got a real opportunity with this new service to enable those calls to go to an alternative service, the Urgent Community Response Service. Now, you know, I want you to bear with us on this. They are new services all across the country, so it may not work as smoothly as we would want it to do in the first instance. But I think we've got a real opportunity to offer a different alternative for patients, where patients will be able to get that care in their own home and not be transported to hospital, because they will get that multidisciplinary team approach in their own home. So we're working with the TSA to develop a decision support tool which will identify then where the best calls need to go, whether they need to go to the ambulance service, because some absolutely still need to go there, but some will need to go to urgent community response services or local authority falls services or a raft of other services. So we're working with the TSA on that. So I urge you to talk to your local urgent community response services and local commissioners around the services and how you can use alternative pathways to help patients get the care in the right place. So, you know, please work with us and bear with us, because it won't be perfect, but it will be over time.
Great, thank you. And Caroline, just wondered, how can tech services work with integrated care systems? How do you think we can make sure that we're relevant to the agendas that systems are developing?
Yeah, so I really think it's about the opportunities we have both at place and at ICS level to really press forward with the developments that Kath was talking about. But I think equally it's about the philosophy that was mentioned earlier about where there's a will, there's a way, and how much more we can actually achieve by working together than any organisation can actually achieve in working alone. And we know at ICS level that there are many, many people receiving care in a location that isn't the optimal location for them. So I think we do have a massive opportunity to be able to really have a seat at those place-based and ICS level forums to actually be able to start that conversation about how care models could actually look different. Not only will they deliver better outcomes for people, but also there's a significant economic case to say that actually if we start operating services in a much more proactive and preventative way, we actually have benefits for people and for the purse.
Thank you. And I think I'm going to come to Daniel now. I think you've got a question for Breed. So are you there, Daniel? Yes.
The microphone. Yes, my name's Daniel Casson from Care England and from Digital Social Care. It is a question for Breed, but it also brings in Caroline, Catherine and Hugh as well, because I'm a great admirer of what's happening in the virtual wards programme, and I just wonder what the plans are for it to actually make use of the best resources that are out there in the community as well, for it to link in. And so that's for Breed originally to start with, but then all the other panel members, what resources they've got in the community that can come in there to make it a really good, even better programme than it is.
Great. So I'll come to Breed and then to Hugh, I think it's first.
Very good question, because of course this is about, you know, keeping people at home, keeping them in the community, and on the purpose, for that specific purpose, the national programme, so the scale up of this to create 40 to 50 beds per 100,000 population by December 2023 is absolutely sitting in community health in NHS England. It's been led by Matthew Wynn's team. We're supporting it, obviously, in the tech enablement. And that's a recognition that we need to ensure we're bringing in all of the resources within community. But equally being really careful, this is not just about putting activity onto community without thinking it through, because some of these virtual ward support can be provided by acute care. But I recently visited a virtual ward service in Leicester, and I was so impressed by the fact that I couldn't tell who was in the community team and who was in the acute team. It was one team, and more importantly, the patients didn't know who, you know, they just had a continuum of care. So I think that's absolutely got to be our aim. And we know workforce is our biggest challenge, so we need to start talking about the bigger team rather than where people sit in a system, I think. But I'm sure others will have a view.
Hugh.
Yeah, very similar. I guess, you know, again, different policy context, but very similar challenges. You know, we know we have a very constrained workforce, and we know that the demographic challenge is going to continue. So, a real emphasis locally on working on virtual wards, but working in a very aligned way with our local authority partners in delivering that, because it is a holistic response we need to our service users, our patients. And I think one of the number of challenges there, disparate systems that we have that we need to bring together so that we are able to get the right information about the right person in the right place, regardless of where they are across the system. So we certainly talk about virtual wards, but virtual wards as part of an integrated whole as a system, I think is really fundamental here.
Absolutely. And I'd be interested in your comments. How do we make that happen? Because there's lots of places that are developing the wards, even within integrated care systems. They may be developing the wards through an NHS lens, and they might be delivering and developing packages of technology-enabled care support through the social care lens. How do we help people to bridge that gap and create one sense of one team working on these things? How are you doing that in Wales?
Yeah, a real challenge, of course. And I think, it's this sense of the genesis of the technology that health and social care have used has been very different. And the bringing together of those technologies in a way that provides some kind of seamless whole, I think is going to be, whoever cracks that has cracked it. And I think that's where industry really needs to focus its efforts, because at the moment, regardless of what's out there, it tends to be, from a health perspective in the home, quite piecemeal technology. There's nothing that kind of is unifying it as yet that gives our secondary care clinicians, our primary care GPs, sufficient assurance that they know people will be safely monitored in the home. So I think there's a journey to go on in bringing that together.
And certainly, Breed, in the system I chair, which is Hertfordshire and West Essex, one of the ongoing conversations is the different understandings and thresholds of risk-taking that exist between consultants, nurses, ambulance conveying decisions, all of those different, and they're not always as aligned as they need to be, or there's not an understanding, or even maybe sometimes trust, that there is someone else who can take and hold a risk in an appropriate way. So how do we begin to break that down?
So for me, if I just take from the supplier perspective first and then come back to that, because I think from a supplier perspective, it applies to both. We need to solve real-world problems. This is not about a tech solution for the sake of tech. This is saying, what is the problem your customer base is trying to solve? And actually, if you can't solve it as a single company, partnerships is a thread throughout everything. What could you do as a collective, and really making sure, and we have a role in the centre on this around standards, but complying with interoperability, because that's where we'll get the productivity gains for workforce, as well as removing some of the reporting burden. And then I think for me, what I've seen in local systems that are successful, it is all about trust. This is about a culture change that we've seen, and someone said it this morning as well, we've seen people work to a single purpose in COVID. I've worked in tech, I moved into tech from clinical tech and improvement since 2003. I've seen nothing like this before. This is a phenomenal opportunity, and the time is now. And I think it's really trying to get people to remember that common sense of purpose around a real world problem. And the real world problem is people are not getting the healthcare they need because of capacity challenges post-COVID. So we really have to all step up to the challenge, I think, and do that as one. But it does come back to trust and going where the energy is. If you've got clinicians who are willing to move forward, and then getting them to speak to their peers, tell their story, what I find really effective is patient stories. We're all in, or people stories. That's why we're doing it.
And Caroline, yes, Kath, yes, please.
Yes, so there's a great piece of work happening in the Isle of Wight. They've got an advantage there in integrated organisation, but the calls going to the ambulance service are then directed to urgent community response teams, but also to the volunteers that volunteered through COVID through the Good Sam app. So some of those calls have gone to those volunteers, which really brings the community as part of that workforce. So that's been a great learning. I think the other thing is to remember, sort of like the domiciliary care staff and the care home sector have got a great opportunity to offer and work with us on all the work that we're doing, because they're integral to the work that we all want to do and need to do for people that we provide care for.
Thank you. Caroline, I've got a question that's come in which I want to ask, which sort of from your perspective with ICSs. So I'm going to read it out because it's quite a long question. So one of the, but don't worry about it. Don't worry. It gives you time to think about it as well. So one of the biggest challenges in driving the adoption of technology is the disjoint between health and social care pathways and funding models. Falls prevention and medicine management being two examples. How, in actual practical terms, will the ICS change this? Keen to hear how Warrington has also adopted a more unified approach. So just to maybe respond to that.
Yeah, sure. Our vision in Warrington is very much to operate as one system with one purpose, and the primary purpose being delivering the right care and solution to our patients, whatever we decide to call them. Now, that doesn't just involve traditional health and social care services, but also a strong partnership with voluntary services and the assets that are there together within the community, and particularly taking a more strengths-based approach to our conversations with people to support them in being able to find solutions for themselves, and having a graduated range of services that then respond to people as their needs escalate. Now that kind of sounds easy to say, but it really endorses Breed's point that it's really about trust and relationships, and often when we're working in a more integrated and partnership way, it's actually about placing the needs of our population over and above the needs of any one organisation, and that is a significant challenge. But for me, my very strong belief is if we can move into that place, we can achieve so much more together than we're able to achieve now.
Brilliant, thank you. And I'm really intrigued, Hugh, that, Director of Finance, it's not normally the title that gets associated with the introduction and rollout of technology-enabled care. And I think one of the things that often will come out is you might be talking to a Director of Adult Social Services or colleagues within the commissioning side of the local authority, and then they still have to run that by and get the sign-off that there's genuine benefit realisation from the point of view of the finance directors. So I guess what would be your advice to colleagues who aren't lucky enough to have an FD who's actually driving this and focused on outcomes, to help them have the conversation with their FD, to give their FD the assurance that they might want to be able to actually invest in this sort of stuff?
I guess I'm not entirely sure why an FD wouldn't be interested in outcomes, because that's why we're all here. And if I think about, value across our system, then that's got to be money divided by outcomes. Well, there is a very clear link there that ought to get buy-in from any finance director. But the reality is that we have for too long been spending our resources where, the pressures are immediately felt in A&E and unscheduled care, in the hospital sector. And that is demonstrably a sector that is not able to deliver best outcomes when compared with what we can do in addressing those kind of further upstream social determinants of the challenges we're facing. Whenever we look at any international comparisons, and Commonwealth Fund in the States do this, comparing health systems from across the world, the NHS comes out generally very, very good on things like access to services, things like efficiency, really poor on outcomes. So we have to have that relentless focus, I think, on patient outcomes and thinking of patients as part of their broader lives.
Absolutely. Well, I think that's a useful message to be playing back in those conversations back when it comes to commissioning these services. So we're nearly coming to the end of this session. So I think I'm just going to go round the panel and just invite each of you, if you were going to leave one message with this audience, who are a mixture of providers of services, commissioners of services, and so on, about how they can prosecute and move the agenda forward, what would that be? So I'm going to start with Kath.
My plea would be talk to your local urgent community response services and find out how you can work together.
Caroline.
I think mine would be open-minded, live in each other's shoes, and really explore what the art of the possible is by breaking down some barriers, and a bit like our speaker said at the beginning, not taking no for an answer. If your gut's telling you what's the right thing to do for a patient or a person, then follow that through. Your instinct will probably be right.
Great.
Mine would probably be, don't think you're starting from scratch. I used to use the term pinch with pride and acknowledge, but actually Hugh McCaughey, who's just about to retire, said harvest with pride, because it probably is more a nicer term. And I think there is so much good work going on out there. Use social media, use the various places you can go, like NHS Futures is one of ours, and find out what other people are doing, or get in touch with people like TSA colleagues, any of us. But don't think you're doing it alone, because somebody else will probably already be starting it.
You.
Yeah, thank you. I'm glad you came to me last, actually. I've had some time.
He'll give the best
should be a good answer now, shouldn't it? I'll disappoint you, I'm sure. I'll certainly be harvesting what I've heard today anyway, and taking that back. But I think there is, I think you said it earlier on about technology at the risk of technology being a solution waiting for a problem, let's make sure we are using technology to address the real-world challenges we have to deal with and be passionate about it.
Absolutely. Thank you all very much indeed. That was really, really powerful set of messages. I think that that's a great takeaway for how we actually are going to embed personalisation, how we are going to make the system more proactive and preventative. And I think it's really, really key message about the one that Stephen said earlier on. Don't forget to ask why, and keep asking why when people come up with the barriers. I think that's really, really key. Can we all share our appreciation to our panel? Thank you very much indeed for your presentations. If you'd like to go off over there, that would be great. Right, so we have one last thing as my colleagues make their way off the platform to do before we conclude. And I dare say that one of my colleagues who thought we were going to do it in a different order will be wondering whether I was going to introduce it now. We have a video which we're going to show you, which looks at some of the work that the Care Quality Commission has been doing, some of the thinking they are doing with the relevance to our agenda. And I think we're going to be able to run the VT, as they say, and be able to run the video from David James. And hopefully, as a consequence of that, we will now see the screen change and the video start. So let's roll the video.
Hi everyone, I'm Dave James. I'm the Head of Adult Social Care Policy at the Care Quality Commission. And I'm really sorry to not be able to be with you today, but hopefully you'll still find what I'm about to talk through helpful and stimulating as part of the session at conference today. And what I want to talk about is kind of how CQC is thinking about the role of digital and tech as part of its future model, and how that sits within our broader strategic direction. So I'm going to set out a little bit of context around what that strategic direction is, what the main ambitions are, a little bit about our future approach and our more structured approach to assessment, and then posing some questions really and some indications as to where we think we need to be focusing, and hoping that that's a good stimulus for ongoing debate and for today's session. So in our strategy, we talk about being really keen to make sure that we stay relevant to the way that care is shifting and developing, so that we're relevant to the way that care continues to be delivered. Of course, we need to be able to continue to manage risk and uncertainty, and we know that we've got improvements to make in terms of our responses to risk and also to improvement actually. And a big focus for us is making sure that we have a mechanism for keeping our published ratings and our assessments more up to date. In our strategy, we're talking about being driven by the needs and experiences of people and communities, really seeing things through their eyes, with a stronger focus on safety cultures and on learning and collaboration across the whole system. So as well as looking at individual providers, this is about how does that provider work with its partners within the system? How does the whole system operate? And we're also going to be looking at how we can be working much more clearly in accelerating improvement and how we work with our partners to deliver that ambition. Really relevant to today's session and conversation is that we want to be much smarter in how we use information that's out there. And that would include, for instance, information that's held in digital care management systems, for instance. And certainly in social care, that's something that we're looking at. But across the sectors, really, how can we make better use of the structured data and insight that is there and that is growing, so that we can then use the best methods to gather evidence? We don't need to do everything on inspection. We've got other means to gather evidence and to gather insight. And we continue to improve our efficiency and build a model that supports a more consistent and transparent approach to assessment and a more effective and efficient way of getting our reports and our findings out there in the public domain. So the cornerstone of all that is our transformed assessment framework. We're moving from essentially two frameworks that we use for inspection. We've got one for health and one for adult social care, and they have evolved over time since we first introduced them back in around 2016. They're quite long, they're quite duplicative, they're not particularly accessible and approachable everybody that needs to understand. So for the public, for people that work in health and care, for providers themselves, for wider systems, that they're just not as punchy as they should be. And we've done a lot of work with our partners and stakeholders to address that. And this framework that I'm going to describe is essentially what we're going to use for all of our assessment and regulatory duties. So you may know that we're taking on new duties in relation to the assessment of local authorities, so social care duties. We're going to be assessing integrated care systems, as well as all registered health and social care providers. And the beating heart of this approach are these I statements, which some of you will be familiar with. Now, these are not CQC I statements. This is what people have said. Good, high quality, person-centered care looks like to them. And really that is the absolute center of what we're doing here. Those statements were co-produced with the help of Think Local Act Personal, and come from their Making It Real framework. And what we've done is we've taken a subset of those and aligned those to our 5 key questions that we continue to ask. Is care safe? Is it effective? Is it caring? Is it responsive to people's needs? And is it well led? So that's the top of the pyramid there. We've then borrowed from the approach that TLAP took in using we statements. Now, these are essentially commitments that providers and local authorities and systems make in order to deliver on the expectations that people have so clearly set out in that Making It Real framework. Now, these are statements that we've developed. That apart from a few, they're not taken from Making It Real. This is what we've been working on over recent months, and you may well have shared your views and shaped that. These are the standards that we'll be holding systems, local authorities and providers to account on. They're pitched at the level of good, and we think they are much clearer and support a much more structured and consistent and transparent approach to assessment than our current frameworks. Moving down to the evidence categories, it might surprise you to know that across our health and social care assessment frameworks at the moment, we've got 335 separate questions. So you'll have heard us talk about key lines of inquiry and prompts. There are a total of 335 of those, which we don't think is helpful. We're sure we wouldn't get any disagreement on that. What we've found in looking at that and in kind of reflecting on our approach is that we're essentially asking 6 questions time and time again. So what is people's experience? What have we heard from staff and leaders? What have we heard from our partners? What have we observed in terms of care delivery or care environment? What can we learn from policies, processes and procedures? And what can we take from structured data, outcomes and performance metrics? So in relation to any aspect of care, whether it be safeguarding, managing risk, or leadership aspects, whatever it might be, we're essentially asking these 6 questions. So all of that will be the same for everything that we go on to do, whether it's system level or at provider level across health and social care. And at the bottom rung, it gets much more specific, because as you'll appreciate, the actual evidence that we would need to look at, the actual training requirements, for instance, would be very different in a residential learning disability service as opposed to a community-based healthcare service or indeed an integrated care system. So that bottom layer is where it gets more specific, and we will be setting out exactly what evidence lines up as part of this structure. And all of this will be kept up to date by maintaining a view as to the current best practice standards and guidance. And again, just to lodge that thought there, as I'll be doing as I speak, thinking about the quality standards framework and how that might actually play into this as industry standard and as a way of informing and maintaining a view as to what good looks like in tech and digital. Just flashing this up then, these are the topics that we have in our framework. There's some change here. So as I mentioned, much clearer on safety and learning cultures under SAFE, disaggregating some of the duplication that we previously had under caring and responsive, being a bit clearer on how collaboration is evidenced and how partners work together to deliver joined up care. And I'll just draw attention, I think, to safe systems, pathways and transitions, as that's perhaps that's a particularly prominent one to be thinking about in terms of how the QSF might line up with these topics. But of course, tech and digital play into all of these in different ways. So to bring this to life then, on that particular quality statement, what people have said, and just to remind you, this is not what CQC have said or not what I think as the policy lead, this is what people have actually said in relation to safe systems. When I move between services, settings or areas, there's a plan for what happens next and who will do what, and all the practical arrangements are in place. And then what we will apply as a standard and what we will look to assess using those 6 evidence categories I've just described is this we statement. So whether it's a provider, whether it's a local authority or an integrated care system, we expect them to be able to say we work in partnership with others to establish and maintain safe systems of care in which people's safety is managed, monitored and assured, especially when they move between different services. So in the Adult Social Care White Paper, there's quite a bit about ambitions around digital and tech. And alongside all of the ambitions set out there, we really welcome what's in that paper and the emphasis on what people expect and what they expect from health and care, from social care rather. Now the focus, of course, and the work at hand is to deliver against those ambitions and make sure that everybody has access to high quality person-centred care. And then for us, this is about how also the Health and Social Care Bill expands our role in terms of local authorities and ASIA assessments. So we need to be thinking about not just what's the roadmap for how we look at tech and digital in providers, but also what does this look like at a local authority and at system level, and how can we get help with that essentially. So there are a number of questions that kind of kick us off on this topic. So in terms of that best practice, what is it? Where do we find that? We're aware of some material, we're aware of the QSF, there's other material out there. How do we kind of corral all this to something that's sensible? So what is safe and high quality in terms of tech and digital? And then how can we look at using information that already exists, going back to that smarter theme, assessments that have already been made, how can we play that into our evidence categories so we're not duplicated? We can just use what's already there and line that up with evidence that we might need to gather ourselves. Along similar lines, how can we harness the insight that's available from digital systems so that we can be smarter? And I mentioned this regulatory roadmap. Given the ambition in the sector to further digitise, and given the support mechanisms that can be in place for providers and others to do that, what's the roadmap that we need to set out there, and what do we agree with our partners in terms of shifting from perhaps a kind of nice to have, good practice, through to, well, actually, you need this kit. You need to be doing things digitally. We can't really see how you can work effectively as part of a joined up system if you're not operating in a digital way. If you're still relying on pen and paper, then we'd have some quite probing questions to ask about how effective that can be and how person-centred and joined up that can be for people. So those are just some thoughts from CQC and a bit of a hint really as to what we're going to be focusing on over the coming months, taking us into the next few years. Thank you very much.
Great. Thank you very much to James for putting that presentation together. And I think it's really quite helpful to hear how the thinking is developing about the role that regulation can play to drive from, if you like, what good practice would be to what required practice might become. And I can certainly see how that links to something that David Pearson was saying earlier on, and the expectation that we think should be there, which is that integrated care partnerships in England should have as one of their elements of their strategies is how they are integrating technology offerings across health and social care and into housing as well. And I think that's another area where one can now expect the regulator to be asking, as parts of their key lines of inquiry, what is actually being done to evidence that being happening in place. We've had some really great presentations. We've had some really, I think, great responses to your questions from our panelists earlier on. I think some really good threading together of the themes that we started off with this morning around unlocking personalised outcomes to how we embed personalisation. And I think, again, the point about how fundamentally this is about people, it's about processes, it's about culture and how we change the way we do things around here and what we believe to be the right thing to do. And I think that really is fundamental to what the agendas that we've been talking about here, in terms of seeing technology not as an end in itself, but as a contribution to how we rewrite our services and deliver better outcomes for people. And I think from my point of view, listening to the sessions that took place after the session here this morning, and listening to the innovation stage discussion, one of the opportunities we need to be mindful of over the next 5 years of the 10-year plan in England for social care is that local authorities will probably go through 2 cycles of tendering their services, at least in that period. So if at the end of the 10 years the tendering has not delivered the transformation, we will have the icing on the cake and maybe the cherry, but we won't have changed the cake. So we have to make sure that over the next few weeks, months and years, we really are pivoting towards making sure that what we buy next isn't what we bought before and actually is beginning to shape that future for technology-enabled care. And I was really excited to hear this morning talk about tech-enabled models of care that actually generate actionable insights and allow you to flex up and flex down the support that's available. That dynamic model, I think, is an absolutely key complement to the virtual ward models that we were hearing talked about by Breed earlier on today, and some real opportunities. And I just end with that challenge from Stephen. The question that we have to ask, whoever we are, when we are confronted by barriers that are not real, but nonetheless seem to be, this is the way we've always done things around here. And that's question, why? Why can we not do something better and differently? That's why TSA and ADAS are working together. That's why we're really pleased to have the panel that has come and talked to us today, all of whom we are working with in one way or another to move this agenda forward. Thank you very much for your contributions and questions during this session today. We now are going back into the exhibition area. We have more innovation sessions and opportunities to network. Thank you all very much for your time.